Thank you. So let me start my part rather than I'm sharing Kiri's presentation. So thank you, Alexandra, and good morning and good afternoon to you all. Uh, Today I will be sharing our experiences in using WHO guides framework uh, to assess the uptake of norms and standard products in Bangladesh. And before I start my formal presentation, let me congratulate Kiris, our moderator of this session, for her dynamic leadership, I will say, in conducting this important and also say time needed multi-country assessment viewing to contribute in improving the quality of life among in member states. So during my presentation, I will try to take you through some background information, including healthcare system in Bangladesh, then methodological approaches that I followed for this assignment, that means field testing of WHO guides framework and findings of field testing, then lesson learned in terms of opportunities and challenges, and then way forward message from this assessment. Uh, Regarding the background information, we all know that WHO has tireless effort in improving the quality of healthcare in member countries by providing, the standard protocols, guidelines. That means these are the norms and standard products, as well as with some other efforts like, capacity building of the, healthcare service providers. But the major issue is that the recommendations in the norms and standard products cannot be used as it is in all member countries, though the evidence base is same there due to the socio-cultural as well as political issues. These some barriers. Thus, local contextualization, or I will say adaptation of guidelines is needed. That's why WHO recommends that every country should follow a systematic way in adapting and implementing process, whether the type of the different types of guidelines they are planning to implement in their own countries, as well as it is very important to mapping the NSP adaptation and implemented process to ensure the accountability of the whole process of adapting and implementing the NSPs. Regarding our healthcare system in Bangladesh, in our constitution, that is the health and nutrition of our citizen is one of the priority issue as the state policy governance, and which has been mentioned in Article 15A and Article 18.1. So Bangladesh, it's a government owned responsibility to ensure the highest quality of healthcare services for the whole citizen in. And Bangladesh has a pluralistic healthcare system, but unfortunately it is unregulated, or I will say the uncoordinated mechanism is there. And the service is provided by four key actors. One is the government, then for profit organizations and non-profit organizations, that is NGOs and foundations on, and then international development organizations and partners. But the main challenges that we face in delivering the quality healthcare services is that is absenteeism of the the healthcare providers, then corruption in the health sector, and shortage of doctors, nurses, or whatever you say the healthcare providers. Hello?
Hello, Salim, you're back.
Yeah, I was disconnected. I don't know why I was disconnected. Now.
Yes, it seems we have had a problem, but you can please continue. Don't worry, and just
okay. Thank
go
you.
on. Thank you.
In this slide, you can see the organizational structure of healthcare service delivery in Bangladesh.
Sorry to interrupt, but you need to share again your slide because we cannot see it.
Okay.
Thank you.
Thank you so much. Let me share again my slides. Okay. So can you see my slides? Hello?
Yes, we can see it. Can you put it in presentation mode?
Fine. Thank you.
Thank you.
I am doing that. Yeah, thank you. So in this slide, you can see the organizational structure of healthcare service delivery in Bangladesh. Basically, it's the Ministry of Health and Family Welfare who is responsible to provide healthcare services in Bangladesh through two Director General. One is Director General of Health Services, another is Director General of Family Planning, and they have primary, secondary, and tertiary level healthcare facilities throughout the country. And Ministry of Local Government and Rural Development and Cooperation, basically, they are responsible to provide, healthcare services to the people living in the metropolitan cities through, urban primary healthcare services delivery package. And to do this, assessment or to this exercise, actually we have taken one guideline, and that is National COVID-19 Medical Management Guideline. And we organized virtual meeting with purposely selected stakeholders. Basically, for this assignment or for this assessment, we communicated with two intensive care specialists, one from Dhaka and one from one district far away from Dhaka, and then one public health professional, basically who is one of the members of the National Advisory Committee to manage the COVID situation here in Bangladesh. So all of them were communicated for this assessment. And now I will share the findings of our assessment. Basically, after discussing with all these stakeholders, what we came to know that the government has a special mechanism to develop or adapt norms and standard products. Basically, it is the Director General of Health Services or any director or line director. They usually take the responsibility to coordinate and standardize the guideline or NSPs. And for the COVID-19 patient management issues, it is the Communicable Disease Control Program, Director of Communicable Disease Control Program. He was the responsible person for these disease or for this guideline. And the ultimate users of this guideline is the clinicians as well as policy makers. But the Director General of Health Services, they developed numbers of guidelines, numbers of documents for the public, and to let the public know what should they do to prevent or to manage this the event, so these pandemic issues. And once it is approved, these guidelines, our Directorate General of Health Services or the specific unit, they upload the document in their website. So information channels, basically it is a sort of, I will say, top-down mechanism that we follow here in Bangladesh. So it is the Director General of Health Services, the responsible unit. They organize, seminar, workshops, or other training sessions to know the end users, the availability of this guideline, as well as to make them acquainted with the with this guideline. And they are mainly responsible for the technical issues of the the guideline. But the budgetary allocation to implement the guideline it is with the, the ministry. So once the guideline is developed, then, the line director, he or she requests the ministry for budgetary allocation to implement the guideline. And sometimes for emergency issues, the budget comes from the, from the higher level, like from the office of the Honorable Prime Minister. Like for COVID management issues, it came from the, office of the Honorable Prime Minister here in Bangladesh. And in developing or adapting any guideline, actually what we do, we usually involve the relevant stakeholders as well as subject specialists. But all of them are mostly, work at Dhaka, in Dhaka. And we usually not, and we usually, don't ask the, the people working in the periphery to be part of this, the process. So this is one of the challenging issues that we encountered during the adaptation or developing any guideline. And in Bangladesh, basically, we have skilled and experienced human resources to adapt guidelines or to develop de novo guideline. And recently we developed 2 guidelines. Basically, I was part of those guidelines. One is, the strategic action plan for lymphatic filariasis elimination in Bangladesh 2020 to 2025, and drowning prevention, strategies. These are 2 things that we developed, and I was part of this thing, the process. So, and the more challenging issues is that in developing, or adopting guidelines that, or implementing the guidelines, that there are some, organizations, or I will say there are the private sector, they look for the profit rather than the benefit of the, patients. So implementing any standard protocol or guideline is difficult in private sector. And in one of my study that we conducted in 2018 for client satisfaction survey, actually in Bangladesh, we have a, patient safety guideline. And when we visited, the private hospitals, even at tertiary level, we did not find the guideline, even the guideline was not there in their facilities. So this is something that we are facing Bangladesh, as well as, the interest of the pharmaceutical company are also one of the major challenge, because they push the, the policy makers and senior level, government officials to work for them. So these are the things that we are facing in, while implementing the guidelines or developing any guidelines. And approval from the DG Health or Ministry of Health and Family Welfare is needed before implementing any guideline. And this is a very lengthy and bureaucratic process. And sometimes it takes months and months and months. The guideline that we developed on, the drowning prevention, it was in 2018. So 3 years, it is almost that it was processed from the DG Health to the Ministry for approval, but it hasn't, we haven't got any approval from the ministries. So this is a lengthy procedure, I can say, here in Bangladesh. And from this, discussion over, virtual discussion with the relevant stakeholders, the things about the opportunities and challenges in, guideline adaptation and implementation, what we learned is that using WHO guideline is a feasible option in assessing the adaptability and applicability of NSPs under accountability framework. But monitoring, evaluation, and learning process needs to be emphasized. Basically, it is missing in both private and government sector, public sector, and also involving the end users or the people from the working at periphery in the process, like NSP's uptake is also a key challenge in Bangladesh. So from these assessments, the way forward message is that WHO guides framework should be part of the system while adapting and implementing any guideline or norms and standard products viewing to improve the quality of healthcare services in Bangladesh. And I strongly believe that it will be the same for other low and middle income countries like Bangladesh. So thank you all. Thank you for patience hearing.
Thank you very much, Salim, for that presentation. So now we can move to the next, to Dr. Aklilu. I will share my screen now because.
So I stop my share.
Yeah, please.
Okay.
Okay, thank you very much. So I'll just Dr. Aklilu Azaj, he's as a MD from Addis Ababa University, Faculty of Medicine, with training in internal medicine and emergency and critical care medicine. He served as a head of medical intensive care unit, emergency medicine program at Black Lion Hospital. He has led several academic programs as associate dean for undergraduate program at Addis Ababa University Medical Faculty and director for graduate programs at College of Health Sciences. He's advisor in emergency and critical care medicine development at Federal Ministry of Health, Ethiopia. Dr. Aklilu has led development of several curriculum in medicine and health sciences and Ministry of Health guidelines. He is the founding member and immediate ex-president of Ethiopian Society of Emergency Medicine Professionals. He has over 60 publications and 10 quality improvement projects. And pleased to welcome Dr. Aklilu. Please, you have the floor.
Thank you, Kadis, for the kind introduction. I am from Addis Ababa University Hospital, and I am presenting COVID-19 guideline development experience. That means the guide test on that. I don't have commercial conflict of interest. This guideline was selected to test the guys because of the emergency phenomena of COVID-19. Therefore, in addition to routine guidelines, this was also selected to see how guidelines are adapted and implemented in emergency conditions. Therefore, what is done is qualitative survey with interview of specialists who did the guideline, Ministry of Health leaders, professional users who used the guideline were interviewed, and this is analyzed, and I am presenting this issue. The objective is, as stated by previous presenters. Therefore, I will directly go to the key findings. The governance, the context of COVID-19, the first case in Ethiopia was identified in March 2020, and so far over 350 people are confirmed, and over 6,000 people died. Actually, this is much more less than the exact figure because these are figures confirmed in the hospital. As long as the governance is concerned, under Ministry of Health Medical Service Directorate, that is entitled to handle clinical cases of COVID-19, it established COVID-19 Clinical Advisory Team, or the CAT, to develop COVID-19 guideline. What is the composition of this advisory team? It is from just different specialists in the clinical disciplines, internal medicine, surgery, pulmonary critical care, public health specialists, but it didn't include other auxiliary clinical staff like nurses, laboratory technologists, and so on. The result is a document was developed after 2 months of revision. As you can see, almost this is just a rapid guideline, and then it was followed by 2 revisions. The document was adapted from a WHO guideline, and the 2 revisions were also followed the WHO guideline. And in addition to that, there were different recommendations were posted in the Ministry of Health website. Almost this was like a live guideline development because of the dynamics of COVID-19. And this guideline was also reviewed by professional societies. And the other important observation in this study was there was no designated unit under the ministry to oversee clinical guide development. Therefore, when we say governance, we are saying some structure in the ministry that is managing development, quality assurance, implementation, and so on. Therefore, that was absent. There was no standing committee, and there was no standard international guidance like AGRI or other tools which are used during adaptation process. When we come to users engagement, users are really very important because there might not be just all side fit of international guide. It has to be contextualized in the local context. Therefore, users should be engaged. In the COVID-19 guideline, when we say users, it is the health professionals who are using the guideline. Otherwise, we haven't surveyed patients or other stakeholders when we say users. In the users guideline engagement, important issue is needs assessment. Because this was emergency situation, detailed need assessment was not done. Actually, the issue was discussed in the Ministry of Health leadership, and the need of this guideline was appreciated. Therefore, that was decided at the Ministry of Health level. And then the users were also decided. The users were clinicians, physicians, nurses, and other clinicians. But unfortunately, there was no much engagement of nurses in this process. The engagement of users or professionals earlier was not really existing, but later on, in the two revisions, professionals feedback was asked, and their engagement was very much active. They even participated in guideline development later on. When we come to decision and the decision maker, it's really very important to always engage decision makers in guideline development, because important people and influential people or influential stakeholders has to be included. Otherwise, there can be obstacles in the process. In this process, in the beginning, there was no strong communication and there was no clear TOR concerning decision makers. In fact, that really caused duplication of efforts and misunderstanding in the process. Learning these problems, clinical advisory team worked on stakeholders engagement TOR, and then after discussion and establishment of communications, the process became much more smoother. Therefore, it helps to build consensus and laid good ground to disseminate COVID-19 updates, because the uptake by stakeholders became smoother. When we come to information channels, information is really very important in its content and also in the whole loop of information management process. That means the dissemination as well as getting feedback and then incorporating information appropriately. In the COVID-19 guideline preparation context, initially in the beginning, because the experts were not experienced in guideline development, it prepared a handbook with hundreds of pages. Therefore, its utilization by the users or professionals was very difficult, and later on, it was abridged or contextualized, and the volume was minimized, and a pocket book was prepared. And then in the third phase, now mobile app is under development. And the dissemination is by the Medical Service Directorate and Advisory Team. It is well disseminated in the Ministry of Health websites, and the soft copy in PDF is disseminated through emails, through letters, through different communication to treatment centers, and different trainings were staged, and this material was disseminated in training and seminar stage. But the problem is, initially feedback was not collected, but later on, they learn from experience, and feedback is collected from treatment centers during field visits, webinar meetings, and also asking from formal letters. And the other important issue is enabling environment. Like a child grows in school, good environment and good ecology is important for guideline development, implementation, monitoring and evaluation. Therefore, guidelines should be really an adult and should be sustainable. Therefore, for this matter, the ministry and partners invested in allocating budget for guideline development, dissemination, monitoring and evaluation for different infrastructure and setup development, and very importantly for health professional training. But the gap which is seen is the clinical professionals, advisory team, and policy makers have no capacity building on guideline development and adaptation or implementation. This was really important gap which was just discussed by the team which prepared the guidelines. And finally, when we see steps for implementation after the document was developed, there were important steps underwent, including endorsement, press release, document distribution, training, supportive supervision, collecting feedbacks, and so on. But that does not mean this is existing in other guidelines, other routine guidelines. But this occurs in COVID-19 guideline because of the COVID-19 guideline, because leaders were very much motivated. The clinical advisory team was very much motivated, and after the guideline was prepared, all these steps were undertaken, but these were not pre-planned. That is very important point which I want to underscore. Then finally, in this process, there are many facilitators. One important issue is Ministry of Health was very much committed, and it worked with other partners. WHO engagement was important. Other local partners engagement was important. That is important issue. The other issue is in-country human resource specialists who are really very keen and just engaging in guideline development, though there was no special training. And the other important issue is in evidence and the quality-based clinical practice, or the concept of evidence-based medicine is at climax or at its zenith. Therefore, this is a very important issue. And then availability of technology like webinar really changed the landscape because they used to communicate with regional centers which are very remote to disseminate the guideline. And though the presence of pandemics like COVID-19, Ebola, and other issues are really bad, it also become important opportunity because government is really very keen on this issue. And there are important barriers. One important issue is there is no unit that oversees guideline development, quality assurance. There is big gap in this issue. And then critical mass of professionals haven't developed with appropriate competency on guideline development. And there is poor link with users, either patients or other professionals working in grassroots level. And stakeholder engagement was not strong, and obviously there was limitation of resources. And as the conclusion and way forward, we see that GUIDES tool is important in evaluation of COVID-19 guideline development and implementation. And as a way forward, we propose capacity building to develop critical pool of professionals is important, and then create a stronger linkage between WHO, ministry, other stakeholders and professionals, and adapt and use GUIDES tool in the local context, and strengthening government of clinical guideline at national and local level is important. And finally, I am really underscoring governance among all this. If there is governance, we can really manage everything. Therefore, somebody say governance is everything. Without governance, we have nothing. Thank you very much.
Thank you, Dr. Aklilu. So now I would like to move to, can you see me? Thank you very much. So now I would like to invite Dr. Alexandra Rodriguez from Mozambique. I'm going to share my screen. Dr. Alexandra is has PhD in medicine from University Witwatersrand from Johannesburg, South Africa. She's an associate professor in the Faculty of Medicine in Eduardo Mondlane University, a member of the College of Medicine of Emergency Medical Mozambican Council. Her research areas of interest include medical education, trauma, and public health. She publishes on medical education issues. Currently, has a research project on strengthening interprofessional education on HIV and health educational partnership. I'll share the screen, Dr. Alexandra, in just 1 second. Can you see my screen?
Yes.
Yes. Go ahead, please.
Okay. In the context of this panel, we are presenting the perception on the real needs of guidelines and norms and standards for health professionals, the case of Mozambique. We have done it as a team with Dr.
A little
Utilia
bit
Neves.
louder, sorry, Dr. Alexandra, just your voice a bit, please. Get closer to the microphone, please. Sorry to interrupt.
Okay, thank you. I was saying that this presentation was prepared also with Dr. Utilia Neves, who is the head of the Department of Medical Emergency Service in Mozambique. In our health national system, can I have the next slide? Yes, please, thank you. In Mozambique, we are talking about a country with a low income and located in Southern Africa with about 30 million of population. The health system is predominantly state and organized in 4 levels. Level 1 and 2, which we consider the peripheral levels, where it is intended to implement the primary health care strategy. In the other 2 levels, the 3rd and 4th, we offer the most specialized and the curative care. Our system is driven by the primary health care, and the intention is to reduce the high levels of morbidity, but also the mortality. And if we saw in the next slide, we have in Mozambique an emergency medical service, which initiative arises from the increasing number of trauma victims, particularly in the last years. The SEMO is taking as a responsibility to train the health professionals regarding the needs to prepare them to be part of the survival chain. It means that SEMO is responsible for preparing all the levels of health professionals in the survival chain. And within this chain, we saw the triage is one of the critical known constraints. And because of that, we decided to assess the high-risk trauma criteria, the Interagency Triage 2 for adults 12 or over years, and the Interagency Triage 2 child less than 12 years. We are working on this because we have to get the standardization of the triage at the national level, and we are looking for the improvement of the healthcare in the national Mozambican context. The triage is a constraint since the ED clinical demand still exceeding the capacity of the resource available. In this case study, we have found that when we regard the governance, we found that governance is a process that is needed in all of the country and regarding all the NSP. At the country level, each department in the Ministry of Health has its own approach to adapt and approve the guidelines. It means that if WHO can approach in other way, maybe we'll provide more guidance in this regard, and particularly when the guidelines are circulating. In terms of user focus, we found that guidance tends to focus on doctors and doesn't address the needs of nurses and other health professionals, and at the bottom, the population as the users. A lack of coherence since the management of the high-level trained health professionals are managed centrally, where the middle and the low and the elementary cadres are managed by the provincial entities. It means that we have to review the user focus in order to provide efficient network. But when we saw the needs, next slide, please. Can I have next slide? Kiddies, can I have the next slide? I think.
Hello, Alexandra.
Yes, may I share
If-
the
No. From the conference room. Actually, Kiris, she told me if there is some technical problem for showing the slides, I can help to do that. But I need, I have the access to show my, the slides.
yes,
So
I think
from
you
the
have,
conference
you have
room,
to
if there
ask.
is anyone from the conference room can help me.
Yes, can you please just share your screen. Do you have your PowerPoint opened?
Yeah.
Yep, just share your screen and go to the slide that exactly.
Okay, can
Uh-huh.
you put the
Okay.
next? Yes,
Okay.
this is
The next
this is the
slide, yeah?
right one. This is the
Okay.
right one. Thank you.
Yeah.
Thank you,
Okay.
Salim.
Can you
Yeah, you're
Can you
welcome. You're welcome. Thank you.
Can you put the previous one?
The previous one. Okay.
Yes. Thank you. Okay, we are talking about the findings and at the level of the needs of the different users, because we understood that we have to approach and we have to support the health professionals at all levels, because our focus is at the primary care, at the most peripheral, and we have there elementary, basic, and mid professionals in most of the case. It means that we have to find a better way to interact with the people who draw the NSPs and the implementers and the adapters. We are Portuguese-speaking country, and we have other problems with the use of the language and with the interpretation. And sometimes it is not easy to have the words really identified as in the way it is needed. It has an impact on the decision and decision makers, and consequently in enabling the environment. Adaptation still a national challenge, but we found that there is a need for leadership from WHO on how to adapt the guidance, taking into account the cultural, social, and economic issues that we feel that can be useful. The stepwise implementation should be taken into account that we are really a low-income country. We are facing every day in everything resource and institutional capacity challenges. The first financial constraint is usually the most common, but we have other issues, and one which should be highlighted in our perspective is that the guidelines in our context take time to implement, and sometimes the revisions come before the implementation finished the previous version, and it take the people be frustrating, and the users most of the time left the NSP. Then we saw the gaps, which is in the next slide. Can I have the next, please, Salim?
Yeah, I am trying, but I don't know why it is not moving. The next slide.
It doesn't want me to finish, maybe.
I don't know the problem. Okay, now it is working. Yeah.
Thank you. The most relevant gaps that were identified were related to the translation. Translation creates challenge. We have to understand perfectly and deeply the contents of the guides, and then to translate to Portuguese and start to implement for different levels of trained people. In terms of language in the NSP, the clarity will facilitate the translation. Sometimes we found terms which can be understood in different perspectives. In other words, can be ambiguous. By translating and maybe with the more clarity in the guides will facilitate our translation. The lack of support on moving behind policy considerations. In few words, it means we need really more monitoring, or we need monitoring because we didn't find this in the process. That's why the biggest gap is the follow-up. Neither the country nor WHO is following up on guidance. And the people who is working with the NSPs, particularly these which we had taken into account, they felt that they are receiving something from the sky. They felt that they are using something which was not prepared to them. And we need to reform this perspective and make the follow-up process, a real process into our health sites. And as a
Again, I am having problem with the, the slides are not moving.
trying to get the last one.
Yeah, but it's it is not moving again. Oh, I don't know.
Any announced steps? We have only one recognized step. We need to develop a network with a good flow from WHO NSP producers to the country implementers. It was what we expected after this work within this group of 5 countries, African countries. Thank you for listening, and that's Olot would like to share with you.
Hello.
Hello, good afternoon.
Hello. Yeah. Is it
Salim?
Dr. Kolela? Yeah.
Yes, I'm the one.
Please look. Yeah. It's yeah. Since Kiris is not online, so you can proceed on, and I can help you. I may have to help you. Yeah.
Thank you, Salim, for this moment. My
Welcome.
name is Dr. Admilabilis Kalolela from Tanzania. I'm presenting information from Tanzania, an assessment of norms and standard product utilization for the management of HIV and AIDS in Tanzania. This work was done in collaboration with Dr. Ahmed Makata. So the Tanzania team conducted an assessment on adaptations of the NSCP for management of HIV/AIDS, mainly on the governance structure, user focus, information dissemination channels, decision makers, enabling environment, and steps involved in implementation. And in this study, the following participants were involved: a medical doctor in charge of the CTC, who is also responsible for adaptation and adoptions of HIV care and treatment documents, registered nurse, who is also in charge of the CTC, and senior service provider, a registered nurse. So these three staffs participated in this assessment. So the findings are as follows. The governance structure. In Tanzania, we have a special governance structure in the form of the organ called National AIDS Control Program and the Ministry of Health. So this NSCP is the primary governance structure for policy making and guideline implementation. In this regard, NSCP is responsible for decision making and all necessary steps for implementation of the management of HIV and AIDS. NSCP also provide governance and a mechanism for adaptations. Also provide information to users and enabling environment as well. So as you can see, NSCP is a primary governance structure, but is collaborating with other development partners and some stakeholders, such as Management Development for Health, MDH. So NSCP is involved and is coordinating adaptations in the following documentation, including guideline and the standard operating procedures, clinical care and diagnostic checklist, and others. And also, apart from that, apart from coordinating these adaptations, also ensures that the documents are available to staffs and also are applicable to the situation of the care and treatment and the implementation of the very guideline for healthcare. Apart from that, NSCP is responsible for capacity building for guideline adaptations. So all these are the main responsibility of NSCP. So it produces also new guidance document as well. In terms of user focus, NSCP also produces and review guidance products based on the needs of service provider and clients as well. So the guidelines and derivative are user focused, in fact, and they are tailored actually to meet the expectations of the clinicians as well as the clients. And they are also they're simple in terms of using it, and they're easy for implementation as well. So the guidelines, most of the guidelines are tailor-made to meet the clinicians and client expectations. NSCP also address the interest of the users as well as the clients. So it addresses also the needs and priority for users because sometimes the users or the clinicians may need particular needs, or they need particular information to be included in the guideline. So they also include in the particular guideline. So guidelines are critically useful, particularly for unexperienced staff, because each time they have to refer back to the guidelines in order to make appropriate management of the HIV/AIDS treatment. And also for even the experienced staff also, they use guidelines as a reference document in case of difficulties during the treatment procedures and other things. Information dissemination channels. NSCP also had the responsibility to disseminate all information. In this situation, supervisors of healthcare facilities are being used. So supervisors are required to give feedbacks and share information with colleagues and staff. And also they need to ensure distribution of soft and hard copies of the guidelines that are produced. The NSCP is responsible to put on its website all the guidelines for stakeholders and clinicians. And also they are responsible for publishing a PDF document or PDF copy for distribution at various health facilities. NSCP provide guidance and support for information dissemination through various activities like workshop or whatever, a meeting, something like that, and distribution throughout the country. Decision and decision makers. In Tanzania, the decision making is down-up approach. Although in some places it's up-down, but in this situation it's quite different. So the implementing staff present the issues and the challenge to facility heads. That means the implementing staff from down, who are really implementers of the guideline. Once they see if there are some problems that need to be addressed, or once they see that the needs for establishments of guideline, then they present those issues and challenges to facility heads. Facility heads would go up and inform NSP for the needs of new guidance or review of the current existing guideline to ensure quality healthcare in the country. So NSP and other experts decide if there's a need to review and establish a new guidance. So they convene a meeting, of course, with experts, and they review the information and the needs from the implementers, and then decide what to do or what next or the way forward. If agreed so to establish new guidance or to review the current guidance, then NSCP and MDH are collaborating together with other stakeholders. And of course, the Minister of Health through NSCP will provide the budget and the technical expertise as well for technical people to ensure that the guideline is well reviewed or is well developed or is well adopted, and the other logistic for guidance preparation and the review activities. The next is enabling environment. Again, we have seen that this NSCP is a very important organization in this country. So it has all this responsibility to provide necessary financial resources for implementation adaptations, establishment. In this situation of enabling environment, the NSCP has established what you call multidisciplinary teams or subnational level teams. These are just few examples that I'm giving you. This multidisciplinary or subnational level team facilitates the implementation and enabling environment in order to make sure that guidelines are implemented. This includes regional and district hospitals, the CTC, inpatient and outpatient services, diagnostic laboratory, pharmacy, etc. There are so many sections. So this just mentioned a few. Yes. The other situation is implementation steps. We don't have very special arrangement for implementation. Actually, implementation steps start immediately when adaptation is completed. Once adaptation is completed from the workshop, the people who participate in the adaptations are given the guidelines, and they go back home or to their facilities and then distribute the guideline to their colleagues and give them information about the new guideline or review information on the guideline. So the guideline, once adopted, is put for clinical use immediately without waiting. There's no time to wait. Immediately, the guideline is put into action. So during implementation, monitoring of the tool depends on individual feedback. So each implementing person or implementing partner is responsible to provide feedback to the appropriate head so that the head will inform the NSCP for necessary action. The implementation challenge and problems are reported also in individual basis. Say if you have any problem or if you have a challenge with using the guideline or the current reviewed documents, then you just report individually. There's nothing like convening a meeting or anything. So this one helps make sure that every problem is reported immediately without wasting time. So NSP's monitoring and evaluation is not actually regular. So it's continuous. In fact, it's continuous. Yeah. Now, although we have seen some good information on this assessment, but yet the challenges are there. And challenges may be even more problematic, of course, for implementation of the guideline. Staff feedback are inadequately considered and no clear channel for communication. So you can see, you can produce your feedback, yet your feedback is not well considered, and there's no proper clear channel. You can produce it verbally or in written format, but there's no clear channel. So this is quite a very big challenge. There's no way, maybe say you have a form to document your challenges or any problem in place. Another challenge is that only doctors participate in adaptation. You know, doctors are just prescribers and nurses are implementers, the real implementers. So, but doctors may not have the real challenge at the ground. They may not understand the problem on the ground. So, but they are participating in adaptation. So this is another challenge. They may not, of course, adapt proper documents in order to meet the needs, in order to tailor the information to meet the needs of clients as well as clinicians who are implementing the guideline. Besides, print copies of guidelines are few. Some have unclear report formats. Most of these guidelines are available online, and you know it's quite expensive for health staff to go and print those guidelines. So print copies are very few, and sometimes implementing partner may find difficult to get the print copy. So maybe they may opt to go to print themselves using their own money. So that's quite expensive for healthcare staff. Observe resistance and misunderstanding, particularly on some issues on guidelines. So yeah, this is of course it's a normal problem and is resolved internally by explaining issues. The main issues is concerning with this reporting format, particularly in the guideline. So reporting format is quite very confusing and it causes a lot of resistance and misunderstanding. We observed also limited capacity for NSCP's adaptation. This is a challenging situation because those people participating in the adaptation do not have appropriate knowledge for adaptation. So they just use their own experience and maybe just normal experience they have and knowledge which they have to adapt. So this may end up in adapting a document which is not very clear or not acceptable to implementers as well as clients. Inadequate supervision skills is, you know, once the guideline is implemented, there's no special supervision skill during implementation. So everybody thinks once the guideline is there, so just put it in place and no supervision. So this is another challenge. And of course, some issues on guidelines are not user friendly. So people may find that, I can't use this one and something like that. Yes. Thank you for listening. And this is my presentation to you. Thank you.
Thank you, Dr. Kola. I'm back. Thank you, Salim, for stepping in. Appreciate it. So do we have Dr. Joseph.
So should I stop sharing or I can
Yeah,
continue?
no, please continue because
Okay,
just it
thank
would
you,
be
thank
easier. I just want to confirm if Dr. Joseph Ngozi is on because everyone is showing here on my screen exactly. So, are you there or not? Dr. Ngozi. Okay, so then can you move to the last slide to the conclusion once and I'll go. Please. Oh, Dr. Ngozi is here. Please, from Uganda. Please.
Yes.
Go ahead.
Yes,
Please do the slideshow view.
Okay, thank you very much.
Let me
Candice.
just do a brief introduction then, please, just 1 second. Thank you. Thank you so much. Okay, Dr. Joseph Ngozi is an obstetrician, gynecologist working at Mbara Regional Referral Hospital, teaching hospital from Mbara University Medical School. He is the Dean of the University of Medical School. He's a fellow of the East Central and Southern African College of Obstetricians and Gynecologists. He holds a PhD in medical science from University of Antwerp in Flanders in Belgium. He's a practicing clinician and researcher, has published in the area of emergency obstetric care. He's passionate about mentorship and building teams and healthcare systems. Now passionate about guidelines as well. Please, over to you. Thank you.
Okay, thank you very much, Candice. Good afternoon to the team. Without further ado, Joseph is my name, and I'll get straight into the presentation. We did a qualitative case study, and here in Uganda on one of the guidelines, and the team that was involved in this work was as listed here: Prof. Ronald Lett from the Canadian Network of International Surgery, myself, and we had 2 junior faculty on board to work together with. No conflict of interest declared, and the brief presentation I'm going to give is outlined in those sub-themes: the background, objective, methods, results, discussion and recommendations, and future directions. In terms of background information, we know that clinical practice guidelines greatly impact health outcomes, whether it's maternal, newborn, or any other clinical outcomes. They do assist clinicians in the diagnosis, treatment, and also further management of different medical conditions. These clinical guidelines are usually derived from evidence-based documents like systematic reviews or meta-analysis, consensus meetings, or practices from other recognized organizations. There is, however, a gap in guideline design by low and middle-income countries, and thus healthcare workers depend on guidelines developed by and from resource-rich settings and other international organizations. So the study objective for this particular review in Uganda was to adopt a WHO clinical practice guideline for Ugandan medical practice using the guides tool. And so we looked at each of the components of this guides tool, and as we shall see further, our results are reported according to that tool.
Next.
So in terms of methodology, we chose one guideline to be evaluated for Ugandan adaptation. And this guideline was the preeclampsia. And this is a guideline that is utilized by practitioners from different health facilities in the country, from the lower primary health facilities to district hospitals to regional referral hospitals and national referral hospitals. So it cuts across. 3 healthcare professionals familiar with the guideline were interviewed in depth, and the questions were largely about whether the guidelines were user-focused, the appropriateness for the Ugandan settings, and their ease of use. So the responses were given in the form of a Likert scale. For the results, the preeclampsia guideline was chosen, like I said before. The assessment demonstrated that there is adequate guidance available to adopt and standardize the specific guideline. However, there are often alternative sources available to manage the condition that are preferred by clinicians and policymakers. The clinicians were the primary users of the guideline in Uganda. They also found to use other WHO guidelines in addition to the Ministry of Health guidelines created for management of that condition that we chose. The Ministry of Health, in terms of information, the Ministry of Health was found to be responsible for disseminating updated guidelines to health authorities who in turn disseminate the same guidelines to clinicians, including the ones that we chose for preeclampsia, eclampsia. And if a guideline is updated, specific sessions are organized for users to update them on guideline changes and their presumed impact. In terms of decision makers, the Ministry of Health Accounting Officer and the technical team, the health facility managers and the clinicians were found to be the key decision makers for the guideline implementation. But also, the Ministry of Health Accounting Officer is responsible for budgeting. The technical team is responsible for the technical details of the guidelines, and the health facility managers who are at the implementation side of the cycle ensure that these guidelines are well implemented together with the clinicians. As regard to the enabling environment, operational structures to implement the guidelines are centered around continuous medical education to orient the users, as well as audits and feedback processes for the guidelines being implemented. The Ministry of Health usually allocates budget lines for guideline implementation and provides both human and logistical support for the process of implementation. Occasionally, resistance is met, particularly when the required logistical support systems are non-operational or they are suboptimal, or in some areas not existent. Pertaining to steps for implementation, there's a critical need to create capacity in developing de novo guidelines, evaluation and implementation, and this was greatly highlighted. It was also noted that to implement any guideline, the process is variable and depends on resource availability. The availability of resources in our setting is sometimes erratic. It's not that all the time they are available, and this poses quite a big challenge. So in regard to discussion, the case study of the guides assessment of the guideline we chose in Uganda demonstrated that guides is a successful tool to undertake the steps required to implement a WHO guideline. Two, a general trend in WHO guideline implementation based on the results of the case study described is that WHO guidelines need to be more available, adaptable, very important, and accessible to clinicians in Uganda and probably other low resource settings. And a standardized process to propose, pilot, implement, and evaluate guidelines would reduce variability, which is usually associated with guideline implementation. In terms of future directions, these results can guide the WHO, who can work in partnership with organizations or individuals or teams to publish medical guidelines to create CPGs for specific conditions. In the case for Uganda, integrating these priority guidelines into their national CPG document would also promote uptake and result in widespread use. So that's the very brief experience presentation that we had in Uganda. We'll welcome any questions and comments. Yeah, thank you very much. Over to you.
Thank you very much. Can you hear me? Can you hear me, Salim? Hello?
Yeah.
Salim, can you hear me?
Yes, we can hear you, Kidis. Don't worry.
Okay, excellent. Okay,
So,
so
yeah.
please put up the slide for me on the barriers so that we can move
Okay.
so that we can move to discussion.
Hello.
Hello, please. Have you
Can you
sharing
s-
the slide?
Yeah, I'm trying to share. Let me go back again.
Don't move.
Okay.
Okay, so I just, while you're sharing, I
Yeah.
can talk. Thank you very much. So as you've heard on the challenges, barriers. Again, summarize. I think this is not the first. We've heard it from the high-income countries' presentations in the different sessions during the conference that I've attended. Depending on what level we're working on, governance, capacity, and the need for users and stakeholder engagement, feedback loop, and resources are always an issue in guideline implementation and adaptation. And these things are even a bigger challenge in settings where we're working in most of these low-middle income countries. Next, please. And then facilitators in general. Next, please. Leadership and collaboration at the global level from WHO, and also in networks like this with the Guideline International Network and other professional associations and organizations. Trust in WHO guidelines and professionals' interest to have, and the professionals interested to have evidence and quality-based clinical practice guidelines from international organizations and other standard-setting bodies. Commitment at the country level from Ministry of Health and other partners, there's commitment. There is local capacity in terms of implementation and local knowledge. I think we've heard from some sessions yesterday, adapting it to the local situation, and technology as it's moving now, and the living approach to guideline development and ranging from evidence review, recommendations, collaboration, dissemination, feedback, all that can be seen as a facilitator. And finally, in summary, there is a need to strengthen the governance, clinical guideline development and adaptation of both for adoption and even de novo at national level. And we need to maximize the efficiency and quality and uptake, like this session says, the guidelines, engagement, and capacity building, and need to invest really to create the enabling ecosystem for implementation and for policy formulation. Thank you very much for everyone attending. I think we can open it up now for questions and answers. And please. I'm going to try to send them to see if I can see. Please, do we have any questions on the panels? Please.
Kidis, can you please turn on your camera so we can see you?
Can you see me?
Thank you. Yes.
Thank you very much. Now, it's just because I lost access to the conference room readings, but there haven't been any questions yet from what I see and from my colleagues telling me. Maybe for next steps in terms of guides is we will be looking for collaboration. It's just, like I said, it's at the early stage of development. We'll be putting out requests for collaborators. We'll be needing writers, meetings, reviewers. There will be systematic reviews that will be done for the different sections. So for anyone interested to reach out to us to find out more, any questions, comments, pdi@who.int. That's product design and impact, just the initials, pdi@who.int. And any questions will be welcome. And so unless if there are any questions, any comments, or even participants, if they have other things to share for each other's work, please feel free. Otherwise, if there are, do you see from the conference room, do you see any questions or otherwise? I think we can wrap up if there aren't any questions, but it's been a great pleasure for us to share this. One of the problems that we see internationally, some of these work are not, if they don't make it into the scientific literature, all the things we develop are there is a gap, and most of this evidence and insights are missed, and the guidelines we put out are not immediately implementable. So for us, we just wanted to use this opportunity, and we thank the June conference for giving us this opportunity to share this work at the early stage, and for all my panelists for taking time and being part of this panel and for sharing their experience with us. Unless there are any questions, I think we can close here. I don't see any raised hands. I don't see any comments. So would that be okay? Thank you. Thank you very much, everyone. And we can end the session here. Thank you for your participation.
Thank you.
Bye.
Thank you,
Bye,
Kilis.
everyone. Thank you.
Bye.
Thank you, everyone, for
Thank you.
participating.
Bye.
Bye. Bye.
Bye.
Bye.
Bye, thank you.
Bye.